Welcome, everyone. We are here to do karaoke. Who's first? Just kidding. No, truly happy that y'all came to be with us tonight to listen to our speakers. Since we have the opportunity, I wanted to just show the memorial care access that we provide to 9 of our Illinois communities. This is primary care and urgent care, and in Decatur we have 5 locations for that. And then also our specialty care is headquartered right here in Decatur. These 2 represent gastroenterology, general surgery, and colorectal surgery, and then we have the other 12 that you can see up there. So blessed to have these specialties in our community. And speaking of blessed, that's me because I get to work with these 2 wonderful providers every day. I'd like to introduce Dr. Singh. He is going to sing what to us? I'm just kidding.
She's a colorectal mom.
There you go.
That was fantastic. That was not rehearsed either. Okay, Dr. Singh joined DMH in 2014 after finishing his fellowship in Columbus, Ohio in 2013. He is a colorectal surgeon that will be sharing his knowledge with us tonight. Dr. Nathan Pyle joined DMH in 2018. He's a gastroenterologist that finished his fellowship in Kankakee in 2018. So very lucky to have them speaking with us tonight. Thank you. Who goes first? Who wants the clicker?
Oh, I get the clicker.
He's bossy.
I'm the boss. That's Dr. Singh said.
And also, before you leave, if you haven't stopped by the wellness table in the back, they have tons of good recipes and healthy tips for us.
And lots of cookies in the back. Don't forget the
Oh, and then the cookies after you get the healthy
Because
tips.
cookies are very healthy for colorectal cancer. That's a lie. I didn't say that. Okay. All right. So this is just kind of a quick little outline of some of the topics we're going to talk tonight. We're going to split between myself and Dr. Singh. So I'll start us off and talking just a little more data at first. One of the first things is colorectal cancer, just how common it is, right? So it's the 3rd most common cause of cancer in both men and women, and the 2nd leading cause of cancer death in both men and women. So it's very common, and it's one of those things that, as I'll talk about in a little bit, is not completely preventable, but almost completely preventable, okay? And that's really the important thing that we're going to try to push here as we try to raise awareness for what colorectal cancer is. Some other things that we talk about as to what maybe puts people at risk. So we get questions all the time. Well, is there something I can do to help prevent colon polyps, prevent colon cancer? And so there is some data on this. It's not great data, but what we do know is that things like being healthy, not being overweight, staying physically active, eating healthy are things that do provide some benefit. So high fiber diet, exercise, decreased obesity. So to kind of counteract that too, so alcoholic beverages, smoking, things like that increase our risk. There are some other things, red meat they talk about, and maybe potentially increasing your risk. They have talked about studies with things like aspirin and decreasing your colorectal risk. The problem with some of these things is they're not a lot of great data, so we don't really strongly recommend if somebody, let's say, has polyps, to avoid all red meats. Take a baby aspirin. There's risks to things too, and taking baby aspirin, for example, every day has its own bleeding risks. So we actually don't recommend people take a baby aspirin every day, but it has been shown to help decrease risk of colorectal cancer.
How about baby aspirin once a week?
So I don't know if there's any data on once a week versus once every day. So it's one of those things as we, of course, get more studies, recommendations change all the time. If you think about for cardiovascular risk, we used to say everybody take a baby aspirin, right? Let's decrease our cardiovascular risk. Well, they then actually changed the guidelines a couple years ago and said, actually, baby aspirin a day, you have, yes, benefit for cardiovascular risk, but you also have risk of bleeding. And the risk of bleeding actually outweighed the risk of cardiovascular risk, the benefit. And so we actually don't recommend just general population, normal average risk individuals, we don't recommend they take baby aspirin anymore.
Just older people?
No, not even older people. Nope. People with a history of cardiovascular disease, we do recommend baby aspirins, but just general risk population, we don't recommend. Age as well, whether you're 50, 60, 20, 30, it's not an age thing anymore. Good question.
Well, I kind of answered I've been taking daily aspirin for like, I don't know, 15, 20 years every day because that's what my doctor recommended.
Yeah, and talk to your primary care doctor. If you have a cardiologist, talk to your cardiologist. But those are fairly newer guidelines within the past 3 years, I believe. And it's, well, remember, guidelines change, right? We get new evidence and new data all the time, and guidelines are ever changing. Same thing for us. We'll talk about some new updated guidelines that we had come out 3 years ago. That's different for us as well here in just the next couple slides.
Just to confuse, his society guidelines will be different than my society guidelines, even within the medical community. So it's very important to kind of keep up with what's going on. Yeah.
Yeah, question back.
Well, I noticed on the previous slide, alcohol.
Mm-hmm.
Do you want to expand on that a little bit? Is that all alcohol or just, is there some tolerance level?
So when we're talking about alcohol, so alcohol is of course a big broad topic, and there's data that will say maybe a glass of red wine will help decrease cardiovascular risk, but there's also moderation, right? When there's a lot of negatives to over drinking, but there are some potential benefits for just having some moderation in drinking. So as with a lot of things in life, the kind of details is the important parts is in the small details. And I think a lot of it's just drinking in moderation, no more than 1 or 2 drinks a day. We're not talking about excessive drinking here. All right, so this slide really just talks about more, if you have cancer, what are the percentages of kind of association with it. The vast majority of our cancers we call sporadic. There's no tie to genetics, there's no tie to family history, it just happens, and we don't really have any other reason besides just you being you, right? Some of those maybe other environmental risks, dietary risks, and things like that. Very small percentage is familial. So familial we have kind of in 3 different parts. There's no little punch on this thing. Nope, oh man. That's the wrong button. Okay, so the little gray box, that's more talk about familial. My mom has a history of colon cancer, my dad has a history of colon cancer. The small little pieces, the blue one and the green one, are more specific genetic abnormalities that we talk about. And there's more than just these 2. These are probably the 2 most common types. One is hereditary non-polyposis colorectal cancer, or Lynch syndrome. And it's kind of a family of different cancers, colorectal cancer being one of them, along with multiple other cancers. Same thing with familial adenomatous polyposis syndrome. Has some other cancers associated with it as well, with colorectal being one of the key ones. So this is where we got some new changes within the past 3 years. So who should get screening for colon cancer? When do we start? It used to be that everybody said it was 50 years old. African Americans 45, everybody else 50. Now it's easy, everybody's recommended at 45. And whether, it doesn't matter race, age, anything like that. 45 years old for regular risk people. Now there are higher risk people, primarily people with first degree relative family members, mom, dads, brothers, sisters. Not that we don't care necessarily about your grandparents and cousins and aunts and uncles, but that for most individuals does not actually put you at an increased risk, okay? And we care about mom, dads, brothers, sisters. So if you do have a first degree relative under the age of 60, you start 10 years before they were diagnosed, or at age 40, whichever one comes first. If you have a first degree relative over the age of 60, you still start at age 40. And there's some other nuances there that we don't need to get all in the nitty gritty about tonight. There's other people, we talked about FAP, Lynch syndrome on the previous slide. We actually start people very early because they're very high risk for developing cancer. And so some of these individuals, FAP, we start when they're just kids, right? 10, 12 years old. Lynch syndrome, we start in their 20s, and then we're going every 1 to 2 years because of that increased risk. So remember 45, that's the big number. There are different screening modalities. There's really primarily 2. Now on the screen we talk about 5 because this is really still what our guidelines talk about. But some of these aren't really used a lot. So the first one is just testing for some microscopic blood. Now this one is kind of fallen out of favor, but this is a more specific test than a lot of people think of the little cards that you get and you put the 3 samples on. That's an old test that we don't really use much anymore. This is a more sensitive test called FIT testing. The next one is we call flexible sigmoidoscopy, and that's a short scope. So it's not the full colonoscopy, it's just looking at the very bottom part of the colon. And that's typically incorporated with doing the blood testing as well every year, and the flexible sigmoidoscopy every 5 years. There's our gold standard, which is the colonoscopy every 10 years. There's a CT colonography, which is every 5 years. That's a special CAT scan. Problem with that one is it doesn't get covered by insurance. So it's not really a primary screening modality. There's another one that's not on the screen, which is a capsule. You swallow a pill and it has cameras in it. Fairly new. We use that technology for some other things, but it's also not really covered by insurance at this point in time, mainstream. So those two aren't really used much. The last one, which is the newest one, is the Colorectal test. It's a special test that tests for microscopic blood, which is the same thing as that top test, but it also tests for stool DNA. And it's one, same screening guidelines, right, for all these starting at age 45. And this one, if you have a positive test, then the recommendations come to you colonoscopy. Now, the very important thing to know about this test, along with all of them, is to know not just what your indications, but what your contraindications mean. Why don't we want to do this, right? So people that have a first degree relative with colon cancer, people with a history of colon polyps, people with a personal history of colon cancer, rectal bleeding, chronic diarrhea, should not get this last test. It's contraindicated. It's likely going to be positive, and you're wasting time, wasting money, wasting resources when you should just be getting a colonoscopy to begin with. Okay.
Now, I understand that after a certain age that older people shouldn't get colonoscopies because of their colon being, I won't say thin, but you know what I'm saying?
Right.
Yeah.
So good question. So guidelines are kind of two-part on that. So the first part, which we have kind of de-emphasized, is the age of 75. We don't focus on that as much. Really, the stronger part of the recommendation is in order to benefit from continued screening, you should have a life expectancy of 10 years, okay? And so the nice thing about that is you're being treated as an individual, right? You're not just a number. It's looking at you and saying, what's your personal history? What's your family history? What do you think? You know, I'm 83 years old. Would I benefit from another colonoscopy? The answer to that is, okay, you're 83. In order to benefit, you should have a good chance of being 93. And for a lot of people, the answer is going to be no, I'm not going to benefit, right? Because colon polyps grow very slow. That's why we have these years in between repeats, right? 10 years if you're normal, 5 years, 3 years, 7 years, all these different guidelines. And so it's a slow growing process. So if your life expectancy is not greater than 10 years, likely something else is going to cause you to pass away
Well,
before
the last
cancer.
one I had, was very painful because after the colonoscopy, we finally got out to a CAT scan. But when he during the colonoscopy, he bumped my spleen. And he did that, of course, it released the blood, and I was in extreme pain.
Mhm.
And he couldn't figure out, he said, finally when he, realized what had happened, he said it happened twice in office practice. But now, I'm kind of, and I'm gonna be 87.
Yeah.
So, I don't know if I should try to do that again. I think, oh my gosh, if that happens again, I was in so much pain.
Yeah.
But he said the reason that probably happened because I had so many surgeries and moved the spleen a little during all my surgeries that I had. Does that make sense?
Yeah, so your spleen sits right behind your colon here on the left side. So damage to your spleen is a well-known risk for colonoscopies, any procedures. It's small. The quoted data is actually 1 in 10,000. In reality, it's probably more common than that. It's just an underreported side effect of a colonoscopy. So it is known. It does happen. And there's multiple things for that. You have an enlarged spleen, you have previous surgeries with adhesion, scar tissue,
Yeah.
and things like that can happen. So it does happen. I think for you, for example, at 87, you really have to sit down and talk with either one of us that does it, primary care, and weigh those risks and benefits and say, what are my alternatives? Is this something I think I'll benefit from or not?
Yeah.
And then making the best case. Nothing in life's perfect. We're trying to make the best decisions on risks and benefits and really what's best for you.
So is it that your colon thins? I mean, as you get older and that?
I mean, it technically it does a little bit, but what I tell my patients is it's minuscule. You gotta remember, your colon is only 1 to 3 millimeters thick anyway. It's a very, very thin organ to begin with, whether you're 10 years old, 40 years old, or 80 years old. And so when you talk about thinning, it's pretty minuscule, and personally, I don't think it increases that risk a lot. It doesn't increase it enough to really change my decision making. My decision making is more based on the other things and talking with you and seeing what really are the benefits.
Well, I almost decided I'm not going to do it again.
And that's okay, and that's okay. You know, as long as, you know, when we're talking to patients, our big thing is informed decision making, right? Telling you what are the pros, what are the cons, what are the alternatives, and then making a decision that's best for you, and that's okay. If that decision is no, then that decision is no. You know, we're not here to force anybody to do anything. We just want to educate and kind of help you out.
So age is a number. We do colonoscopies on 90 plus all the time.
Mhm.
I have the oldest one is 101.
Huh.
Yes.
Yeah.
Yeah. So age is a number. We put you as a whole. We look at the benefits. What are the benefits we're trying to achieve? What will be the complication? And informed decision making. We tell you all that, and then you make a decision.
Yeah.
Nobody's gonna force anything on you.
Right,
You
right.
are
Oh,
the
yeah, I
captain of the
understand
ship.
that.
Yeah.
Good questions. My last slide, and I'll give you one more little tidbit. So we have, of course, goals, right? Our goals are to screen, I think it's the goal, I think initially quite a few years ago was 85% was our national goal. We are very, very far short. Now, the bar graph looks like we're increasing nicely. If you notice, it's only 65 to 69, almost 70%. So it's only about a 4% increase. And so it has not increased nearly as much as we would like. There's a lot of reasons behind that, but it is something that we are trying to work, of course, increase access and whatnot for people to try to help get more people screened. Colon cancer is one of those unique things I said at the beginning. It's almost completely preventable. Okay, now there's going to be those outliers that you're not going to find that meet outside screenings, are younger individuals, right? That's part of the reason why we decreased the screening age to 45 instead of 50. But when you talk about, let's see, other screenings, right? Women get mammograms, we get pap smears, lung cancer screening for smokers, prostate exams. You know, most of these are just trying to find cancer at an early stage and then address the cancer. Colon cancer is completely different. You know, colon polyps are what turn into cancer. So our goal for colonoscopy is to find the polyps, remove the polyps, and by doing that, we're preventing cancer. So this is all preventative, and that's the beauty of the colonoscopy versus some of the other screenings is colon cancer doesn't typically have a lot of symptoms early on. You're not typically having pain and bleeding or obstructions and things like that. Those are late findings. And so waiting until you have a symptom of something, it's typically going to be too late at that point in time. Okay, so you don't want to wait. You want to get the screening done, and that way you can prevent those problems. And for the Cologuard, for example, it's a good screening test for cancer, right? It'll find 92% of colon cancers, which is good. Colonoscopy is not perfect either. So colonoscopy is about 94%. So it misses colon cancers too. The beauty of the colonoscopy over Cologuard is that it will find polyps. So big aggressive polyps, Cologuard only finds 40%. For small polyps, it only finds 20%. Okay, and that's all nationally published data. And that's where the benefit of colonoscopy, in our opinion, beats the Cologuard, is because it's all about prevention. It's not about finding cancer. And that's what I will leave you on.
All right, thank you, Dr. Pyle. So my job is easy because Dr. Pyle put in such a good foundation. So this slide, if you look at it, explain how the colon cancer will start and evolve and then become a cancer. So the way I want you to think about this is think about the lining of your inside your mouth. So think about that's the lining of your colon. And now you're exposed to certain environmental factors. Could be radiation, could be certain foods we eat, people working in X-ray department. So many number of things. So all those risk factors we talked about, they will cause certain changes in those DNA cells lining the lining of the colon. And that will give rise to a polyp. A polyp is a growth. Think about this as a mole. So then there will be more changes as the time progresses on. You will make more changes, the polyp will grow bigger and bigger, and eventually will lead to cancer, which is called carcinoma. And then, if we don't find that in a good time and did not address this one, it can spread to the other parts of the body called metastasis. So again, the whole talk for today is to find something at the early stage, and then we can address it and prevent all these other issues down the road. Even if we find carcinoma on stage 1 and 2, which we're going to talk here in a second, it's completely treatable. So that's the importance of doing this screening colonoscopy, staying up to date on all, and don't miss and actually educate everybody around us. So this is a very powerful slide. Once you get the visual, yes, this is why it's preventable. Now, does every cancer does this way? No, but 98% of the cancer follow this sequence. There are certain genetic cancers we talked about, less than 5%. They actually go through a different mutation and they grow faster. For this sequence to complete, it takes about 5 to 10 years. Hence, in between colonoscopy, we usually say 10 years if we don't find anything. But the other cancers, they grow faster. So we do every a year or two, depending on what kind of cancer you have. So if you look at the distribution of the colon cancer, in this talk, we're gonna put colon and rectal cancer together, called colorectal cancer. So rectum is the last 15 centimeter of the intestine from the anus, and the rest is the colon. So majority of the colon and rectal cancer you can see, they're in the rectum and the left side of the colon. And the 1/3 are on the right side. So you saw one of the slide was flexible sigmoidoscopy, only using the small scope. And if you do that, you're gonna miss all the cancers on the rest of the colon, so that's why we don't feel strongly that that's the good test. Colonoscopy is the gold standard because you're gonna cover the entire colon, and now the data is coming out, more and more people, especially the young people, they're having colon cancer on the right side compared to the left side. So it's very important to screen completely, not incompletely. So, yes ma'am.
When they have a sigmoidoscope, how far up do they go?
So they will go from your anus up to here,
Oh,
about 30 to 40 centimeters or 45 centimeters. The colonoscopy will be all the way
yeah,
where the colon ends. Now, the length of the colon is roughly your height plus half a feet plus or minus. So if you're 5 feet, 5 to 5.5 feet. 5.5 feet is just longer than me.
I had about 18 inches.
Yes, just to give you a perspective, so, yeah. So once we make a diagnosis, I think I should come on to this one a little later. We have to stage a cancer. Once you're diagnosed, Dr. Pyle has done the scope, he found something, or I've done the scope, or any other colleague, then most likely I'll be seeing the patient. I'm a colorectal surgeon. There are other surgeons in the hospital who do the similar surgeries as well. So once we have a new diagnosis of a colon cancer or rectal cancer, it needs to be staged. What is the meaning of staging? The meaning of staging is we want to know what is the distribution of the disease. Is it only confined to the colon wall or the rectal wall? Is it going outside the colon and rectal wall into the surrounding lymph nodes, or has it gone to the other parts of the body? So this picture, I don't have the pointer, but if you look at stage 0, that means it's just a mole. It's very, very early stage. It's not even a cancer yet. If we don't do the colonoscopy, didn't do any of the recommended modalities, that will grow into a cancer. But stage 1 is the first 2 layers of the colon or the rectal artery wall. It's a very, very early stage. Stage 2, it has gone through layer number 3 and layer number 4. Stage 3 is different. Now the cancer has left the colon wall and has gone to the lymph nodes. And stage 4, it has gone from the colon wall into the lymph node and the rest of the body. And those organs could be anywhere, but most commonly it will go to the liver, lung, brain, and bones. Okay? Once we find the cancer, we do the CT scan of your whole body so we can understand what is the stage. Sometimes we'll do a PET scan, which is a little bit modified form of a CT scan. There are different reasons why we do one versus the other, but the whole idea is to do the imaging of the entire body. You might have heard PSA. In prostate cancer, we check PSA. In colon cancer and rectal cancer, we check CEA levels. We want to get the baseline, and we follow them by 6-month checkup, because once we find cancer, we have taken care of the cancer, the CEA levels should not go up, they should stay within normal, or if they were high to begin, they should fall to normal. So after 6 months, if the CEA level goes up, oh, that's an alarm to us, something is growing back, so we start looking so we can catch it early, treat it early. As we talked about, stage 1 and 2 is only the colon wall. The tumor has not left the colon yet. This is where it's curative. People come to me, I do the surgery, you're cured. Again, very important to find cancer early stage. Do not wait for the symptoms because none of these early stage cancers will have abdominal pain, rectal bleeding, or any symptoms of obstruction. So they are silently growing. That's why we need to do the screening to find these guys early on. Stage 3, now the disease is in the lymph node. Do the surgery, but you will need chemotherapy again. Again, treatable, not incurable, it's treatable. Stage 4 is now different. The cancer has left to the other parts of the body. Is it curable? No. Is it treatable? Yes. The goal is to give you as long life possible, disease-free, but you will be going through surgery plus and minus chemotherapy, sometimes radiation therapy. So again, early stage cancer have a better outcome compared to the late stage. Everybody good so far? So the way we do surgery nowadays is laparoscopic, and in this hospital we do have a benefit of robotic surgery. I do robotic, laparoscopic, as well as open surgeries. The benefit of doing something laparoscopically is to make small incisions. Inside the surgery is the same. There's no difference in surgery. The outcomes are the same. It's the benefit which we derive from making small incision, that being less pain. You recover faster. You're not in the hospital for 2 weeks. Most of my patients are gone in 3 to 5 days, and some of them actually day number 2. They can return to their activities way early compared to somebody who has a big open incision. Also, big incisions will have a high risk of hernia formation, wound infections. That's the benefit of making small incisions. You are overall doing great. Cost is indirectly related to all those because you're spending less time in the hospital. It's less cost to the healthcare, less cost to the patient. So that's another benefit. This is an important slide. People want to know, hey, I have a stage 1. Is it 100% curable? What's my life expectancy from 5 years from now? This chart kind of summarizes. When you have a stage 1, one of the best survival 5 years. Those numbers might be a little off, but majority of the time it's 95 to 97%. Stage 2, somewhere from 85 to 95%. Stage 3, it will start decreasing, 75 to 80. And stage 4 will really go down. So now you can see the benefit of treating early, catching early. You have a good survival. In summary, what we want you guys to focus on from today's talk, with our advances in technology, screening, the incidence as well as the death rates are on decline, and we want to improve that. We want you to do all the right things. Eat right, exercise, avoid smoking, all the risk factors we talked about. Screening saves lives. I don't think I need to explain that. You guys just witness all the reasons. Most people get screened because the doctor told them, but nowadays, because of the social media, the talks like that, you're gonna learn something, you're gonna tell your families and friends, and that also spread the word, so you tell people. There are so many advances in the this cancer care. New chemotherapies, new surgeries, advanced surgeries. People like me also do an extra training after surgery residency to become more focused on colon and rectal surgery so the outcomes are better. DMH is actually Rectal Cancer Center of Excellence. Dr. Pyle and I are kind of part of that team, and I'm the program director for that too. So we're doing really good with that. Now, this last point, we are becoming more and more personalized with the treatment of colon or rectal cancer. We are finding certain tumor markers. Everybody's tumor marker might be different. You might be different, you might be different. So once we know those, the treatment for you will be customized differently, and for you will be different. So we are actually going in that direction. And we believe maybe in a decade or 2, we might not even need surgery and a lot of stuff. We might be finding these early on with the stool-based test, which are on increasing on the horizon. Find these things, make this thing customizable to you, and outcomes going to be so better compared to what we have right now. And I witnessed a couple of meets in the last couple of months. They're coming up with so many of these COVID kind of tests which are highly sensitive. They're not even missing those 20%. They're only missing 5%. And I think the reason for that is we are running out of money in the CMS healthcare system, and they want to come up with more and better stool-based tests, but they still don't approve these tests unless they have less than 5% miss rate. You don't want to miss, that's the whole point. The miss rate for colonoscopy is about 5, so they want to approve the test which will miss less than 5 to compare colonoscopies to the stool-based test. Until then, the colonoscopy is the gold standard to me. Yeah. With that, I believe we conclude, and questions? Yes, Sarah.
Hi.
Hi.
She had a question. Okay, cool. So just two quick questions.
Yes, ma'am.
What is the lymph node? Hi. And then also, if you do, does it come back? So say you're at stage 1 or 2, you clean it out. Is it likely to come back? How does that work?
Yes. So let's define lymph node. Think about your heart is pumping blood, it's go to the tissue, you perfuse those tissues, they get all the oxygen and all the nutrition, and then whatever is left over comes back in the venous blood back to the heart. But not all the blood comes back. Some 5 to 10% left over in the tissue is filtered through another system called lymphatic system. So they are microscopic vessels, you don't even see them, you see them under microscope. But they do have these bean-like lymph nodes, that's where these lymphatics will start. But those are the first areas, so those are called lymphatics. They are usually around the organs. You can feel them in your groin actually, those little bean-like structures, that's lymph nodes, under the axilla, but they're all over the place. That's where, so let's put it this way, some of the cancer will go to the lymph node to spread, some will spread through the blood. Colon and rectal cancer primarily spread through the lymph nodes. That's why it's very important to capture those lymph nodes so we can stage the patient and treat them accordingly. To answer your second question, we said surgery is curative for stage 1 and 2. What you saw on the slide, the 5-year survival is not 100%. So yes, it's not 100%, but it's close to 100. Does it come back? Yes. The reason we think it comes back, maybe we are not smart enough with the imaging, maybe that there was already some kind of spread to the lymph node, but we just could not catch with the CT scan because our current technology does not allow us to do that. As the stage goes up, the risk of recurrence goes up, especially with 3 and 4. Obviously, 4th is already spread. With the stage 3, that's why we want to do chemotherapy to catch all those microscopic cells which we did not see on imaging to kill them.
The other part I say about that too is, once you've been diagnosed with cancer, you've had your surgery or chemotherapy, whatever it might be, the other part of that from the recurrence question is follow-up, right? We're not just doing the treatment and then that's it, right? There's follow-up, right? We do, depending upon if we were able to make it through the whole colon or not, we do a follow-up either within 3 to 6 months or within 1 year after your surgery and treatment, right? And then you're doing 3 years, then you're doing every 5 years. So part of it is, yes, making sure you're not missing one of those 1 or 2 minute cells that you just missed, right? Nothing's perfect. So even if you have one cancer cell that escapes the surgery and chemo and everything else, it only takes 1 cell, right? So that's part of it. But the other part is there another cancer that develops near it or even away from it? So you don't want to forget the follow-up because it's not always just that initial cancer. It might be a secondary cancer that has popped up or that you missed in the first place.
Remember we talked about CEA levels? So that's the reason we check every 6 months. So if they start going up, we get alert, so we start checking again. So there is a follow-up after a colon or rectal cancer surgery. 1 year after the surgery, you get a colonoscopy, and then based on the findings, every 3 to 5 years. 1 year after the surgery, you get a CT scan of your entire body. So those are the protocols. So I tell my patient, you're gonna see me today, you become my family for the next 5 to 10 years. You're not done. It's not gallbladder, I take it out, you never see me again. So all my patients are close family, and half of the patients we share with each other, so we know them pretty well now at this point. Yeah. Yes, sir.
I've been reading a bit about stem cell treatments. Is that advanced near enough to where it could be used? Do you have any use of that in treatment?
Not in the colorectal world outside the trials yet, but some of that diabetes, hypothyroidism, there are good data coming out, even sickle cell anemia. They're actually, it's not like trial, they have tried on patients and they have worked, but everything else is in a trial phase, like very early trial, especially in colorectal world, I don't know anything yet. But I think we'll get there, that's the personalized medicine, it's coming.
One other thing, I've had a number of colonoscopies over the years, and it might be helpful to know, it seems like the last couple of times, the preparation was a lot better than what we used to have to go through. I think they've got some new fluids or whatever to, instead of drinking a whole big jug of stuff, so I think that's something people might want to know, not be afraid of what they heard 10 years ago, what you had to do.
So colon preps change, it's medicines, right? So we get new medicines all the time. Colon preps are the same. They come out with a new colon prep every several years. We had actually a big cycle of about 3 new preps in the last 5 years. And we have a new pill prep that came out 2 years ago now. You still got to drink, a fair amount of water with the pills. It's a lot of pills, 12 big pills. You drink a bunch of water, 12 more pills, and a bunch of water. The only benefit over the pills, over the liquid, is you just don't taste it, right? Think of it, if you dissolve those pills in the water, that's your liquid prep. So once it hits your stomach, it's going to dissolve. It's going to do the same thing as the liquid prep. You just don't have to taste all the salty, flavor going down that you do with the liquid preps. Ultimately, at the end of the day, you have to get clean. So I tell my patients, you're going to poop your brains out, right? It's not a fun night. It's busy. You're up and down off the toilet. But it's 12 hours. It's not like you get a GI bug and you have no clue when this thing's going to end. I feel miserable. It's a short period of time. The benefits are well worth that kind of 12 hours of not fun time.
Think about input, output. You always want to be well hydrated. So you might be taking a small amount of fluid, but we always say you have to drink a lot. What comes out need to be replaced, otherwise you will be very dehydrated. You don't want to do that either.
Any other questions?
Yes.
Okay. So I've seen so many people, they say like lymphatic drain, stuff like that. But they say that if you fast, you can regenerate your cells, dry fasting, not eating. Are those the type of things you should do to prevent colon cancer or any kind of cancer, like, really restricted diets, or like, what should you really do to prevent colon cancer?
You want to address that?
Yeah, so a couple of things. Another example that I give my patients too, from a diet perspective. We talked a little bit about the diet at the beginning. And we see this in a lot of evidence if you look around the world, right? So here in the United States, we have a lot higher prevalence of colon cancer versus Asia. Asia has a lot higher prevalence of gastric cancer in its diet, okay? And that's been really well shown in different studies, when you're comparing the different types of cancers. And so, simply, yes, we know that diet is a component. I think part of the problems are, one, we have a little bit of evidence saying, okay, red meats have a higher risk, and I mentioned that at the beginning. But it's also probably cumulative, right? It's not like we're just talking about you stop now and you have no further increased risk. We've had a lifelong of environment exposure, radiation exposures, not just working in the radiation department, right? But we get radiation damage to us all the time. And so it's a lifetime exposure. So doing one thing different now isn't necessarily going to decrease that risk real significantly, which I think is part of the reason why we don't have a lot of strong recommendations to say, if you have colon cancer, avoid all red meats and don't do red meats ever again. Only stick to your fruits and vegetables and those type of things. Yes, that's important, but it's important as a bigger global picture in my mind than just specifically for colon cancer.
Also, remember that we talked about sporadic. The way I explain is bad luck. You didn't do anything wrong. You just happen to be in that spot. That's why it's very important to do screening, because people think I don't have family history, I don't have symptoms. And we just discussed early cancers, no symptom. Majority of cancer are bad luck. That's why screening colonoscopy. So fasting, if you look at fasting, what you're doing is you're actually making your body fit. You're losing weight. Obesity is one of the risk factor for colon cancer development. So it's indirectly related. But as we talked, it's a cumulative thing. Just just cannot change one thing and think I'm done. Good question.
Any other questions? All right, well, thanks for coming out. We'll stick around for a little bit. If there's any further questions you guys have, please feel free to ask us. But thank you so much for coming out and have a wonderful evening.
Thank you, guys.